Welcome to Swallow the Gap, the podcast that delves into the critical world of dysphagia practice and education. I'm your host, Dr. Tim Stockdale, and I'm thrilled to have you join us for conversations aiming to bridge gaps in understanding, knowledge, and implementation surrounding dysphagia intervention. We will be a force for change by inspiring critical thinking, facilitating discussion, and promoting professional development. Swallow the Gap is here to discuss, inform, inspire, and connect you with a vibrant community who is dedicated to making positive change. Together, we'll unpack challenges and be open about our own struggles and work to bridge gaps in our field that impact the lives of those living with swallowing difficulties. Our opinions should not be taken to represent our employers or the groups with whom we associate. Nothing we say is legal advice, and nothing should be taken without scrutiny. While we strive for accuracy, we do not imply perfection. We value diversity in backgrounds and opinions, so our guests will not always reflect what we believe. In fact, we may change our minds on topics as we learn because this is how progress is made. Through discussion, critical thinking, and open minds, we serve as catalysts for advancement in medically focused speech-language pathology. Being able to critically evaluate research articles is a vital part of our profession. Understanding this appraisal empowers us not only to discern if the research is sound, but also if it transfers to our specific patient population. Today, Dr. Corinne Jones delves into how SLPs can analyze and interpret clinical trials to facilitate translation of the science into our clinical practice. Today, we have Dr. Corinne Jones. She is an assistant professor at the University of Texas in Austin in the departments of Neurology and Speech, Language, and Hearing Science. She also works 1 day a week clinically in an outpatient setting at the University of Texas Austin Health. I remember meeting Dr. Jones, or Corinne, thank you, as a doctoral student in Florida at Gainesville. There was this normal swallow physiology conference that Drs. Emily Plowman and Ian Humbert had put on. Very insightful, but that was a fun conference. And so that's the first time I remember meeting you. And so subsequently, I feel like every time I've run into you and asked you a question about your graduate work, it's been like, what was it like working with Dr. Plowman? And that's sort of thing too. And you're like, I went to the University of Wisconsin-Madison. Like I was just there for a bit. So anyway, apologize for that. And so no one is confused. Where did you tell us a little bit about your background in education, if you don't mind? Where'd you get your degree? What were you doing in Florida?
Yeah, of course. So I'll go backwards in time. So I did my Ph.D. at the University of Wisconsin-Madison. I actually did a joint Ph.D. in speech, language, hearing sciences and neuroscience. I wanted to really dive deep into understanding the foundations behind swallowing. Mm-hmm. There's a dumb joke that I used to think the brain was the most interesting part of the body until I realized, wait, who's telling me that? So I was
biased there.
Yeah. But I was very fortunate to be able to do some work with Drs. Plowman and Humbert in helping them get set up with high resolution pharyngeal manometry, which is a technique where we measure pressures in the throat and esophagus during swallowing. And so I was invited to present some of the manometry work that I had done with Dr. Tim McCullough in Wisconsin, present that at the Normal Swallowing Conference. And so happy to be associated with those brilliant minds who used to be in Florida, but really owe quite a bit to my mentors, Tim McCullough, Michelle Chucci, and Marina Emborg, who is a primatologist actually in Wisconsin. And so doing my PhD in both programs gave me a view of what SLP, communication sciences and disorders, was like, but then also research in neuroscience and just how it's different and not necessarily worse in one or the other, but helping me really understand the foundations of what we see in clinic, but also not losing the forest for the trees of trying to figure out where things are branching and all of that, to always keep that patient in mind.
I found that very valuable, just the different backgrounds that people bring into SLP. We don't always have to just study speech pathology to become better speech pathologists, or always study the physiology of the swallow to become good diagnosticians or good therapists for swallowing. That there are a lot of other skills that you can bring from different areas that really help you to get an outside perspective and bridge things together and see things from a way that we wouldn't have seen it if we're all just, oh yeah, I did my undergrad in speech-language pathology and I did my graduate studies in speech-language pathology, and here I am as a speech-language pathologist. And that's fine. You can do great that way. But I love it when people come from background in philosophy where they really works with critical thinking or neurology or any of these other areas. It adds depth to what we do.
Absolutely. Yeah. And swallowing is a symptom of other underlying conditions. And it's a consequence. It's not a condition in itself. Dysphagia is not a condition in itself. And so we need to pull from other fields so we can really have a well-rounded approach, both clinically and in research.
Yeah. And there's not enough time to cover all of those in a graduate class. So this is something going back to trying to design curriculum and whatnot, is thinking of dysphagia, like you said, it's a symptom. And so we want to know, why that's important, what causes it. But just getting into all the different disorders with the limitations in education we have, that's extremely difficult. And also what we're going to go into here in a moment about interpreting articles or clinical trials, pulling that away, we can understand that some, and we learn some of that in graduate studies, but we don't have all the time in the world to do it. And also, as a student, sometimes you don't have the big picture perspective of why these things matter.
Yeah.
Hopefully we can.
Yeah. An example of that is when I was doing my Ph.D. program, it was my last class that I took. I was in my third year. The start of my third year is my last kind of sit down academic class. It was an undergrad class in kinesiology about motor learning. And it was just like mind blowing of, oh, this is what I do. Really talking a lot about the types of feedback that we get and how that influences motor learning and the types of practice schedules. And like, oh, well, I do this as a speech pathologist. If I am treating swallowing or voice or speech, they're all motor tasks. And unless you're doing only like pure cognitive or pure language, the way we practice these things can influence, and the way we instruct our patients can influence that. I'm sitting in a classroom with sophomores and juniors, undergrads. One of the courses where I learned the most. I've really tried to incorporate that in my teaching, incorporate that kind of motor learning perspective for like the students that I have here at UT. If they're looking for different electives, I try to guide them towards that perspective, because that can have a huge influence on the efficacy of the work that we're doing, is how we're interacting with the patient. We don't really get that instruction.
Absolutely. That's brilliant. I don't know how I would map it out, but I wish that our undergrad was take some of the courses, keep some of the courses, but give us a broader science background in general anatomy and physiology, kinesiology, and these different areas that can give us a whole body perspective on things that are happening. So anyway, I could tangent about that. So I can save you all that soapbox for right now. But so one of the things that you said you were very interested in is clinical trials. And there's so much, this is hard for me to put into words. So I am just going to put it back over to you. Why is this something that's special to you?
Yeah. So when you invited me, and thank you for the invitation to talk here, but with your whole purpose of filling in the gaps, that I took a step back and thinking like, okay, what in my perspective is a gap in practice, or what have I heard from clinicians are their perspectives, in that there's this gap between research and practice. And so another thing I've also heard from clinicians and struggled with as an instructor is how to learn how to read these articles and then translate that information into what we can do in practice. And I just listened to the episode you did with Dr. Alicia Vose yesterday, and I think this kind of helps dovetail into that in sitting with the not great state of dysphagia rehabilitation evidence we have, but then as new things come out, what can I do to dive into the nuance and to get things that I can apply into my practice, and then the how to do that. And so I thought that's a good way to help bridge the gap, is give clinicians tools to actually access and digest what's happening in the research world, and to give a window into what that looks like to help when a clinician has a really great question about a patient, a really well-informed question, how can they go about finding the answer to that question in the literature or addressing their practice if that question hasn't been answered.
Okay. So like you're going to give us a little distilled mini PhD here to be able to go out and do what we need to do.
Right. So so I have heard that, oh, I didn't learn how to really critically read a research article in grad school. And that's a skill that you need as a clinician to be able to interpret the research out there, the evidence out there, and then change your practice as a clinician.
Yeah, there's
And
so much to learn. It really is difficult in a 5 or 6 semester program to get the depth and everything that we need. 9 diagnostic categories, and to learn how to be diagnosticians and therapists, to learn about motor learning and to learn about interpretation of research. So
absolutely.
yeah.
And maybe your professors did try to teach you how to read a research article, but you were also learning what an MCA stroke is and how to write a SOAP note and what the difference between spastic and ataxic dysarthria, and like thinking about how to get your 2 o'clock client to just sit down and do the therapy activities that you planned.
Absolutely.
But I think this is what's great about this podcast, is really enriching that continued learning. And when thinking about this, I thought back to my undergrad statistics class, which I took first semester freshman year. It's at the time it was an ASHA requirement to get into grad school. And so I took that instead of taking a math class in my undergrad. But coming away with it, really the only thing I remembered was the normal distribution curve and that there was a thing called a t-test.
It did something.
Right. Yeah. And Albert Einstein said that education is that which remains when one has forgotten everything learned in school. So that was my statistics understanding going into grad school. But then when I was a first semester PhD student, I did another statistics class. And when I went into my PhD, I had already had some experience in research. So I was an undergrad research assistant, and then I did a master's thesis. And then during my CF, I also worked as a research lab manager in Dr. Tim McCullough's high-resolution manometry and swallowing physiology lab. And so I had that experience with research and how to collect data, and I didn't really do a lot of the statistical analyses because I didn't understand it, but I had the steps of how to design a study and how to collect data, and then once that was analyzed, how to interpret it. But then once I had that kind of foundation and I took my PhD statistics class, even though the statistics class was out of the forest and wildlife ecology department, and so we had examples about farm fields and cattle, but in my mind, I could change that to penetration aspiration scale scores and tongue-based pressures. And I had that framework to map it onto. As a freshman undergrad, I didn't have that research framework. But as a first-year PhD student, I had the time and the experience. And so then it was a lot easier for me to digest that information and then apply it. So this is why I wanted to talk about that. So for the people who are practicing out there who may have had a research methods course or one lecture in their grad program on how to read research, but now that you've been practicing and you have that context to get some that refresher and to maybe do some practice. And
yeah, absolutely. That's one of the hugest things to me is when we're learning something, if we don't have the overall context for what it is, we don't have any the ability to be able to integrate it as well. We don't even know what all of the terms are. So what I also appreciate about this is your ability to take this and relate it to clinical outcomes or case studies and so on. So not just, you imagine a statistics class, oh man, that could be like one of the most boring things ever for some people. But now these individuals who are listening, they have their people who they have worked with. They have a way to conceptualize this, as you were talking about in your PhD statistics course. Even though it was in an agricultural program, you could take that and apply it to what you're doing. I really excited because I know I'm going to learn something, and I think it's going to be super neat to see how you really take it and focus on the relevance. So I'm going to let you take it away.
So first, just to give a little bit of context of what, at least my perspective of what faculty researcher life is like and my motivations, and then hopefully that'll inform a high level of what research is out there. I have in my particular position, and there are different flavors of faculty out there, faculty and researchers, but I have four main bins of my academic life. So I'm a teacher. I teach in the master's and the undergrad program in speech language hearing sciences. I'm a researcher, so I need to get grant funding to pursue grants and then do the work and publish and present. I am a clinician, so 1 day a week I see outpatients, specifically in swallowing and dysphagia. And then another bin is service. And so I do service for the university. So I serve on different committees. I read all of the master's student applications for people who are applying to our program and
Go on
score them in
podcasts.
various different ways. And I go on podcasts and I present at conferences and I serve on a couple nonprofit boards. And so just that giving back.
Yeah.
And so there's a lot of different things on my plate. But again, I really enjoy it because I am serving people who are impacted by dysphagia. But going back to that research bin, you, as a faculty, you develop your independent line of research. And so it's a thematic structure that you are doing. All of your research studies are tied together into a theme, or you can think of multiple themes. And so personally, my independent line of research is in three interconnected aims. And so I've called my lab the Swallow Modulation Lab because I'm really interested in how we can change swallowing. So in order to know how we can change swallowing, we need to be able to have accurate measurements of it. And so I'm really interested in the data piece behind swallowing and understanding and measuring physiology, both in healthy and dysfunctional swallowing. And then I'm interested in how different health conditions impact swallowing, particularly in Parkinson's disease and then also in multiple sclerosis. Okay. So how using that data from that first piece and then applying it into those clinical populations. And then third is how healthy people and then people with Parkinson's and MS, how they can change their swallowing, how they can volitionally change their swallowing, what we do in rehabilitation. And so all of my kind of work flows into one or multiple of those areas within my line of research.
Okay. And it seems, from what I understand of it, to be very focused on things that are translatable into everyday practice, which I would assume that'd be hard to do as a researcher, because with the expectations and the rigors of how to design a study and recruiting participants, and it's just so many limitations with that it would be challenging to be able to make something that has, I'm not going to say challenging to make something that's clinically relevant, but maybe more clinically relevant than most research, or easily understood by clinicians such as myself and whoever, to be able to apply to our patients, right? Because
absolutely, yeah. And so in developing the independent line of research, there's not like a rule. It's not like you have to have 3 sub questions, or it has to be clinically relevant. So in order for me to survive and thrive as a faculty member at the University of Texas at Austin, I have to show productivity in my research. And so it has to be something that can get funded. And so I have to then think of things that are novel and exciting to potential funding agencies. And that's the main portion, the things that'll get funded and things that'll get published. So thinking of the different intricacies of getting a study published. But the kind of clinical applicability, that's something that's going to be personally driven by each investigator. So if I could get studies on patient perceptions of swallowing margarine versus butter, if I could get that funded and I could get that published, that could lead to me being successful as a researcher, though it's on the researchers to have that clinical applicability.
Yeah, that's what I love about researchers who are speech pathologists who are still practicing, because you get to see things every week or every day or however frequent. And I think that prompts real life questions. At least I always have the
Absolutely.
most
Yeah.
questions when I'm out practicing. I'm like, I don't know what to do here. I know there's this study that says something would help a patient with this physiological presentation in a population of head and neck cancer, but my patient just had a stroke. And so how would that apply? I don't know. They're just those nuances that are out there.
Absolutely. Yeah. And I think that's what makes our field, researchers in our field who are clinicians, so much stronger. And then having a lot of experience in the neuroscience program in my PhD, my colleagues, my cohort members had so much more biology and
Yeah.
other training that I could barely understand some of the work that they did. And then I had to remind myself in my imposter syndrome that I have this clinical expertise and I can really relate everything back to that versus someone who just went from undergrad into a PhD program
Yeah.
in biology and not really having a sense for that kind of impact.
Absolutely. And giving credit to the complexity of the process of oropharyngeal swallowing of the aerodigestive tract, that's a lot because people might say, oh, you study swallowing, not realizing the complexity of it. Like how many muscles, how many cranial nerves, how much interplay between sensory and motor processes. So I don't know. That's it. To me, it's really cool. And I think that's definitely a positive credibility to your ethos at that time. If I was there and you had the imposter syndrome, I think I would probably have it too, but those are probably some reassurances that I would give you and everybody who's listening to this, that there's so much depth that then we understand. And that's what I really appreciate about these conversations.
Mm-hmm.
So anyway.
Right. And no diss to any biologist who has never seen a patient, and they have so many skills that I will never have. But yeah, knowing that I know more than I think, and I have more experiences that is going to inform my work. So yeah, the kind of thinking of how to develop your line of research and how to get things funded and to get things published, that has a lot of influence of what research is out there. And I think Alicia talked a lot about our reliance on assessments and kind of those observational studies, is that it's a lot easier to do that than to design a randomized clinical trial and to recruit all the participants and to make sure that they stay in the study and all of that. Just it's so much more difficult and complex to do a treatment study, even though that's what we as a field have a really big need for.
Yeah, those are our outcomes that we're going for.
If I can, before I go up for tenure, if I can publish, I have not published this many in these years, but if I could publish 20 observational studies versus one clinical trial, someone who's going to be at the university looking at my packet says, oh, this person has 20 publications, this person has one publication. They will look deeper into what is in the publications, but there's a numbers game to it. The number of publications is a very important metric for getting hired in a faculty job and securing tenure or getting promoted within a faculty job.
So almost like
unfortunately, that might lead to some of the bias of these studies. It's just logistically easier to do that.
So like competing interests as a clinician and as a researcher.
Mm-hmm. Certainly. And also, one thing that kind of motivated me to go towards this topic is I do have an interest in clinical trials. And just a disclosure, I haven't published any clinical trials, but I have things in the works. And I'm very interested in preventative rehabilitation, particularly in Parkinson's disease. So knowing that with the progression of the disease, swallowing will get more difficult and what can we do early on. But in order to do one of these really complex, hard clinical trials, I need to have some more answers first before jumping in. So I have a small grant from the NIH to collect preliminary data to support a bigger grant of just understanding how dysphagia progresses in Parkinson's disease, what fails first. And that'll give us understanding into how we can approach a preventative rehabilitation.
Oh, absolutely.
Paradigm. And so if I were to jump in and say, okay, let's do EMST and effortful swallow in these people with Parkinson's who don't have dysphagia, that's not well intentioned. And I could be wasting time and a lot of money and a lot of energy. And so having that strong rationale is going to be very important.
But I think it's also going to drive clinicians' motivation to read the research, because
Absolutely.
if your priorities are their priorities and it's relevant to their clinical practice, then it's going to make sense for them to go into. There was a case that you had mentioned during your CFY. Was it an individual with a medullary stroke?
Yes. Lateral medullary syndrome. Yeah, she was in her 50s. I had seen her in more of a research capacity. I was working with Dr. Tim McCullough, and he had high resolution pharyngeal manometry. And I was his lab manager, but then I also helped him do clinical manometry studies. And he had seen this patient who had I think it was about 2 years prior to when I had seen her, had a lateral medullary stroke and severe dysphagia. So expectorating secretions and NPO, a PEG tube. And I had seen her at the very end, but she had gone through 2+ years of different types of behavioral treatment, a UES dilation, myotomy. I think she had a couple laryngeal framework surgeries just to try to address her swallowing. And then when we did the kind of final high resolution manometry and video fluoroscopy, she was able to tolerate mechanical soft diet. This was pre-IDSI.
Yeah.
So my translation of that, I think level 5, and then thin liquids. She had to do a couple of compensatory strategies, but was able, and then she had her PEG tube removed. She was so happy. And then I was really surprised with what we saw on the manometry. So manometry, again, we measure pressures in the throat and the UES and the esophagus. And typically we see pressures in the pharynx, usually around 100, 150, 200 millimeters of mercury as a maximum pressure. So we need to constrict the tongue base against the posterior pharyngeal walls to put positive pressure on the bolus to drive it down. And then we need to open the UES to have a place for the bolus to go. We also need to close off the airway so the bolus doesn't go in the airway, but we don't have that information on manometry.
Yeah. So you're looking at certain muscles to come together and generate more pressure, and then certain muscles like the cricopharyngeus to have less pressure when needed.
Absolutely. Yeah. It relaxes and then it's pulled open. And so there's a larger space in the pharynx, and that gives that subatmospheric pressure to act on the bolus. And at the time, our primary research study in the lab was to collect manometry data on healthy individuals. And so I had seen probably at the time 100 cases of healthy swallow. So I knew what a healthy swallow looked like. And then I was completely blown away with this patient who had a functional swallow, eating everything by mouth. She had very low pressures in the pharynx, so on the order of maybe 45 millimeters of mercury max, so very low. But the pressures that she was able to achieve in the UES, the upper esophageal sphincter, and in the esophagus were very low. So negative 20 millimeters of mercury. And so she was essentially like somehow probably figured out how to use the muscles of the rib cage or the diaphragm to create this large area to have these really subatmospheric pressures to like pull the bolus down.
That's so cool to see how people compensate in so many weird ways.
Right. I wasn't part of her rehab team, but she wasn't trained to do that. Her last rehab protocol was doing tongue strengthening. So actually with Dr. Joanne Robbins, she was doing her tongue strengthening program. And so nothing about tongue strengthening would have influenced that, but likely she had figured out that this was a strategy that worked for her.
If we were looking at this patient, say on MBS IMP, numbers would be pretty sky high. And if we maybe just had those numbers, you would think, oh, this person is probably never going to swallow again or something. I mean, is that kind of bad?
So it was bad, but again, it was to the point where she was able to have an oral diet and protect her airway and not rely on a feeding tube and not have any pneumonia events. It would still not be a great swallow, but functional. Yeah. And then looking at, if you just saw her manometry, you might think, oh, she's not going to be able to get anything down. But then just that really opened me up to thinking about swallowing as a dynamic system. So how do these different kind of components of the swallow work together? And then
Yeah.
what's like the main necessary component of that? And then how do we achieve that in therapy?
Yeah. So that's one of the things that I remember learning, writing MBS reports or a number of other things. I would see residue on the tongue. And so I was told, you've got to explain why. You've got to explain why the residue is there. But it was just like this equals that. Oh, there's residue on the tongue. It's reduced lingual strength. There's residue in the vallecula. It's reduced base of tongue retraction. You see penetration. It's reduced high laryngeal elevation. Just all of these things. It's like, if this, then that. Very linear, very formulaic. And I have learned that it's just not like that.
Mm-hmm.
That's not
Yeah.
like.
Yeah.
And so I know that's one of your soapboxes, is this idea of this kind of univariate of ignoring some of the nuance. And that seems to really play into this case. Like if you were to look at their tongue strength, it's awful, but their swallow is functional. And
Mm-hmm.
so do you care
And
to?
so, yeah, what's going on here? And then how can we replicate that in another patient who has a similar problem?
Mhm.
And then how does that lead to thinking about rationales for our treatment? So coming back to our clinical trial is when we do therapy for a patient, what's the rationale? What are we doing? And then what's the evidence that we know of that actually works to act on that? Things might be more complicated with these kind of multivariate dynamic systems, but how does what I do as a patient, how do I expect that to change their swallow? And
Sure.
so if I can go back to like, okay, so how do we digest research? And how can if I have someone sitting in front of me, they have these signs of dysphagia, they have this certain pathophysiology. Now what do I do? So we look to the literature. And so there's kind of two broad classes of types of research. One is observational and one is interventional. So an observation, and this is back to what Alicia was talking about in her episode, is that assessment piece. So if you're only doing an assessment, if you're saying that people with Parkinson's disease have a greater incidence of aspiration than people without Parkinson's disease. That's just, if you think about how you would design it or how they actually designed it, if you bring someone in for one study, one visit, and then see if there's a difference, then that's an observational. You're not actually changing the outcome of that patient. So, or also like if you do an effortful swallow, that makes pharyngeal pressures go up. That makes the UES open wider, like in the moment. That gives us proof of concept evidence that an effortful swallow might be helpful in therapy. But in order to really have causal evidence to show that if I prescribe this treatment, then it will have this change, then we need to do an interventional study. So if you're reading a paper and it says effortful swallow resulted in greater pharyngeal pressure than non-effortful swallow, mm-hmm. then that's an observational study. If you read a paper that says over 8 weeks of EMST therapy, PAS scores were reduced, that's a clinical trial.
Okay. Very cool.
And so if you think back to when we did learn about research, if you had that kind of training in your program, there's that pyramid of evidence. The peak is the systematic review and meta-analysis of randomized controlled trials. Sure. And at the bottom is case studies or opinions or sometimes animal work. So our highest level of evidence, if what we're going to do for our patients is at the peak, is if multiple people have done randomized controlled trials to address a certain question, mm-hmm. and then we combine all of that data, then that gives us evidence that it is effective or not.
Yeah.
This doesn't mean to say that what's at the bottom of the pyramid is not important. It's actually flipped. It's the foundation. It's the foundation of the pyramid. So we need to have these case studies, this basic science, this animal work to show that we have the rationale for doing such a clinical trial.
Very integral steps within the process to get to the peak.
Absolutely. So me saying that randomized controlled trials, like a double-blind placebo randomized controlled trial is the best evidence, doesn't mean that a case study is worthless.
Oh, yeah, for sure.
So just saying that before we go in. So, like I said, sometimes you'll see or hear people say RCT, that is randomized controlled trial, and then sometimes you'll hear a double-blind RCT. So, randomized means that you collect your group of participants, potential participants, and then if they meet certain eligibility criteria, you randomly assign them to one of two interventions or multiples, whatever intervention. And the purpose of doing that is to allow the groups of participants in each different type of intervention to have a greater chance of being more similar.
Yeah.
So if you didn't randomize, you might have some bias, intentional or unintentional, in saying like, oh, I might have more 80-year-olds in my experimental group and more 50-year-olds in my standard care group or my control group. And so if you randomize, then there's a random chance that you're assigned to any one of them. And so that helps to wash out those baseline differences.
So basically, it helps to minimize the impact of baseline variables. So differences that people have coming into the study, because you're measuring an outcome and you don't have that confounding variable in there, this variable that like, well, all of these people did this and it resulted in that. But also all of these people had, I don't know, brain tumors, and all of the other people in the other group, like they were fine. So that, like that sort of
exactly,
thing, like,
yeah,
to an exaggerated degree.
Absolutely, yeah.
Okay, cool. All right.
And then controlled means that there's a comparison to the experimental treatment. So sometimes it's like standard care. Sometimes we'll see that, and it's whatever they would be getting if they weren't in this trial. Sometimes it's a sham. So if you have a fake NMES device that is attached, you put the stickers on, and it might give a little buzzing at the beginning, but it essentially doesn't do anything. Or like if in those cases, so when you do a clinical trial, you want that comparison to group to be as close as possible to the experimental treatment, but minus that meaningful variable. So say NMES, you have your patients in the experimental group with NMES and it's on to whatever specifications that you have in your research question. And then the comparison group is doing the exact same treatment at the same level of intensity, just not getting the stimulation. And so then if your experimental group shows a difference after therapy that the sham group did not, well, then you have causal evidence that the stimulation is what caused that change.
Okay. Makes sense.
So that's how, when we're thinking about how to design these, we want it to be as close as possible. And there's an ethical issue in our field with doing nothing, just because we're treating dysphagia and there's a need for intervention if they're eligible for our study. There's ways to kind of get around that. So you can do a delay entry. So say there's a waiting list. And so for 8 weeks, your patient's on the waiting list, and then they start the experimental treatment. And then, so you have a baseline evaluation, an evaluation after the waitlist period, and then an evaluation after the treatment period.
Sure.
And then you can compare it to people who started the treatment right away. And so then you have that comparison of not getting anything.
So in that case, kind of one of the controls is just their baseline overall. The
Absolutely. Yeah.
Okay.
Yeah.
Fair
and then you may read a study and they talk about crossover. So that means that, group A got the experimental treatment and group B got the control treatment. And then after a certain amount of time, they switched. Then group A went to the control and group B got to the experimental. So then everyone in your study is getting this experimental treatment. Then you can also see that, compare that within a particular individual themselves, within a particular patient. You want to make sure, again, if you're doing this, say like comparison to standard care, if you can't, if there's something logistically where you can't have, say like a sham, you want to make sure that what the participant is, what they're getting is as similar as possible to the experimental group. So if your experimental group is 2 1-hour long visits a day for 3 weeks with EMG biofeedback, And the control group is like one visit explaining how to do the Shakir exercise and nothing else.
Yeah.
We don't know if it was the biofeedback or if it was the amount of time that they came in, the interaction between the patient and the clinician. And that's something that we need to be able to match. And then that's something as a reader of a clinical trial, you can try to dissect. So like, oh, well, they did this really intensive treatment compared to one visit explaining how to do the Shakir, and then that can help you be a critical reader of literature.
So basically, you want everything else other than the variable that you were trying to show has a correlation or a cause. You want everything else to be as similar as possible. When people are going through and reading the methods, they need to be looking for things that are different when they're trying to evaluate the rigor of a study versus just reading the abstract and seeing these patients did this, these patients did that, and whatever happened, because all these threats to the validity of the article, does it really measure what it says it measures? Does it really prove what it says it proves?
Absolutely. Yeah. And then, so that was, we talked about randomization and controlling. And then we want to talk about blinding. So again, that kind of top type of clinical trial is that double-blind randomized controlled trial. So blinding tells us if the participant and or the researcher knew what they were getting, knew what they were participating in. So thinking about like a drug trial, you as a participant, you might get a bottle of pills and they're not labeled, and you don't know if it's the drug or if it's a sugar pill. And then, so that would be a single blind.
Okay.
And then a double blind would mean that the clinician or a study team member, they don't know what you're getting. They don't, like, they got this bottle of pills from the study sponsor and they don't know if it's the real drug or the experimental drug or the placebo.
But basically, so their intervention isn't subconsciously affected by what they know is happening.
Absolutely. Yeah. And yeah, so this is all to protect against bias. And so subjects want the study to succeed. And so they're spending their time and their energy to participate in this study. And so they want it to be successful. And so they might do things, if they know if they're in a particular group, they might subconsciously do things that could change the outcome. Similarly, researchers obviously want the studies to succeed or have certain biases about what they expect to see. And so they might subtly change their behavior or change analysis of the data to know of that. And so that also brings me up that we also have blinding and data analysis too. I wouldn't want a research assistant of mine to be scoring modified barium swallow study on whatever outcome if they know, like, okay, this is the post-trial evaluation of someone who participated in the control group.
The temptation to make it work, whether or not you do it consciously, subconsciously,
absolutely,
such a risk.
Yeah. In swallowing behavioral research, it's not always possible to blind. So say if you're doing like a chin tuck versus thickened liquids, obviously the patient's going to know what they're doing.
Yeah.
Obviously the clinician's going to know what they're doing. And there's not a way to get around that. But researchers can be really creative in like trying to find ways to create sham devices or subtly not deceive participants, but so there's an example in a certain kind of brain stimulation called TDCS, transcranial direct current stimulation, where you can like physically feel a skin sensation from having the electrodes in place on the scalp. And to have that sham is that they turn it on for a little bit and then they turn it off, and they tell the participants like, oh, you might stop feeling it because you'll get used to the sensation. Mm-hmm. So they can feel it turn on, but then it turns off and they feel like the patient feels like they have just acclimated.
Very interesting. I bet you probably have to get pretty creative in figuring out how to
certainly. Yes. Yeah. So that's kind of that apex randomized control trial. You might see clinical trials out there that are not randomized or that are not controlled. And that doesn't mean that they're worthless. Oftentimes we need feasibility data before we can do a big randomized control trial. So like to know that a CMG skill training has the ability to change someone's swallowing function, I might do a pilot study that is not randomized in a small group of people to show that, this intervention changes function. And then now that gives me evidence and greater chance of getting a bigger randomized study funded.
Yeah, absolutely. And less likely to waste your time on something if there's
Absolutely.
not evidence to support this hypothesis.
Yeah. Yeah.
Very cool. Very cool.
Yeah. And so then as you're reading, you want to think about like, okay, how is this designed? Is this randomized? Is this controlled? And for randomized controlled trials, there is a kind of metric to a protocol to help with reporting of it. It's called CONSORT. It's the Consolidated Standards of Reporting Trials.
Okay.
And so it's a kind of a checklist to make sure that you have the necessary information reported in the article. So, Tim, I've given you a link to a PubMed article that kind of outlines this CONSORT and these things that should be reported for every randomized control trial. It's from an orthodontics journal, and so it's not relevant to swallowing, but as we talked about before, we're kind of getting out of our field in order to bring those learnings back into this field. And I thought it was just a kind of well written, easy to understand kind of breakdown of what the CONSORT checklist is.
Yeah, no, that makes a lot of sense. I appreciate that resource, and I'll get it to make it available along with a couple of others. One thing, so you've talked about a lot of the rigors of research, things to look for, just some not going to say basic things to look for, but some very important things to look for within the methods, with the purpose of helping clinicians to truly understand if this article that supposedly showed whatever outcome with tongue strengthening or with EMST or whatever it would be, first of all, like if that the methods were good, so it did really work for that population like they said it worked, but also the piece of external validity of taking that and applying it to your population of the patients you're working with. And that's like a whole nother piece of that. You've talked like a lot about this internal validity. Does it really measure what it says it does? I don't know, maybe we'll follow up and get some of this external validity. Like what do we do when some study is normed on patients with ALS and I have a patient with Parkinson's or with multiple sclerosis? How do I take that and see if it applies? Because that's not exactly what the study looked at. And I mean, there are a lot of reasons why the study didn't throw people with MS in and people with Parkinson's and ALS. And so we better understand that now that you want to be equal, or you want to match these things, but it also creates a barrier for clinicians to be able to interpret that, because unless it's studied in all of these groups, it's difficult to understand how to apply it to our patient. One other thing that we were chatting about, so you had mentioned as far as the applicability of research to what we're doing clinically and how there are differing things that allow researchers to keep going, and in some ways differing priorities, but a lot of overlap with clinicians. But you got to stay funded, get tenure so you have a job. And clinicians, but then there is overlap in things that match, that researchers are going to put out a lot of information that's very clinically relevant. One of the things that I thought was very interesting that you brought up was this idea of frequency of treatment after a stroke. And that's something that's extremely practical, but we don't have a lot of information on.
Absolutely. Yeah. So that kind of stems from, I lurk around a lot of SLP Facebook groups, and oftentimes I see people post, for example, this frequency question is, what's the evidence on how frequently I should see my patient after having a stroke with dysphagia? And to my understanding, that study doesn't exist yet. So a couple of things I want to touch on here. First is, if you're ever making that post or reading that post or having that question in your head, check to see how you're wording it. Okay. So instead of asking, say, is there any evidence that effortful swallow reduces residue? Ask, what is the evidence of the effect of effortful swallow on residue? So asking, is there any evidence that effortful swallow reduces residue? That opens you up to confirmation bias, because in your mind, you already have this connection of effortful swallow and reducing residue. Okay. And then subconsciously you may weight research that disputes that. So with that, you might say, oh, well, this doesn't really apply. And you might then more highly weight evidence that supports your pre-existing notion.
Yeah.
And then rethinking, then you say, okay, so what's the evidence that effortful swallow impacts residue? That just opens your mind up to take in confirmation and denial evidence. And then if there's a question that you have, a clinical question that you have that doesn't have an answer, think about, is this something that would be even like possible to study? So then going back to think of a clinical trial design, patients in the acute stroke ward, how would you, looking at frequency of treatments, how would you design that? So you'd have to get people with acute strokes. Then are you going to take people with only cortical strokes or brainstem strokes? You're going to have to exclude people who have other conditions that could presuppose them to dysphagia. Oftentimes it's really hard to recruit people who aren't able to give informed consent, who aren't able to make those conditions. It's possible, but it's a lot more difficult to do that. And so if the patient with stroke comes in and their POA is activated, their power of attorney, then you're going to have to get in touch with them in order to get that secondary consent. So it's not the patient can't consent themselves, you're going to have to get that surrogate consent. And so just like logistically, it's going to be hard. Then you also then design, okay, so I'm going to see this patient once a week versus I'm going to see this patient twice a week versus I'm going to see that group every day. And then people have different levels of dysphagia and different things that you're going to do and ethical considerations. And what happens if they're discharged on day 3, but they've been randomized to the ICU every day group? And again, not saying that question doesn't have merit, but it's just very difficult to study. And then if, depending on your question, you could also think about, is there a way that I can address this in my own practice? So if I'm at a big hospital with a big stroke center, could I look back into my records and ask a question is like, okay, well, can I find a group of patients who are relatively similar to each other with just, we had a high census this week, and so they didn't get a lot of follow-up versus we had a low census this week, and so they got a lot of follow-up, and just see if they had any different outcomes. And then, also, what are your outcomes? Are your outcomes evidence of aspiration? Is it reduced laryngeal vestibule closure reaction time or increased reaction time? Is it readmission with pneumonia? Is it discharge disposition? What are you going to measure?
Yeah, absolutely. How do you measure those outcomes? Do you think it is, so anytime, I think there's a whole lot of good that we can get from taking outside principles and trying to incorporate them into speech pathology. And so while we don't have a study that's robust and great for determining frequency of dysphagia therapy after someone has a stroke, we can, I guess, kind of right now we're left with, I want to say left with, because that implies that everything I say is that's all we can do. And someone's going to think of something else to add to it that's a better idea. But so we're left with kind of this idea of looking at like neuroplasticity. And so frequency matters, intensity matters in what's been shown to work in other areas, and the hope that transfers to what we're doing. But then we've got to measure and be unbiased in our measurements as a clinician. There's just so much to it, but it's kind of the starting point. Do you think, oh, you got me, because I'm asking this close-ended question now. I'm like, how do I ask this in an open? I don't want to bias things in my head. What do you think the evidence is for these principles of neuroplasticity having a very close translation to swallow function?
Absolutely. And that, again, is going to be very dependent on the consideration. So staying in this acute stroke question of, okay, so knowing how the brain is impacted by a stroke and the different phases of inflammation, neuroinflammation, and how that can influence function. Like we might see that if the patient's still in a healing phase, their brain is still healing, then doing an intensive program might not be the best. But if they're in more of the subacute or chronic phases, then they might need that intensity. So then bridging what we know about rehab science and neuroplasticity, and then kind of the neurobiology of stroke and recovery from stroke, that can help us come to an educated guess of what is going to be best to do for our patient who's sitting right in front of us. Because we're never going to have the evidence for, okay, so what am I going to do? What swallow exercise am I going to do for my patient who's 3 days post-stroke? He's 45 years old, African-American, 36-year, or not 36, 16-year history of smoking. I'm not going to have all of that just because there's not going to be the infrastructure to have that. And so we just need to be able to sit with what we know and what we don't know, and then make our best reasoned decision, taking into consideration the patient's perspectives and their values, and then taking data. Is what I'm doing working? Is it changing? Alicia brought this up, and I love this, and I tell this to my students, is that you are a scientist when you're a clinician. You use the scientific method. So you get the consult for this 45-year-old male who had a stroke, and you say, okay, so like, what do I know about age-related changes to swallowing? What do I know about impact of stroke on swallowing? What do I know about the potential for smoking to influence respiratory function? And then what do I hypothesize that I'll see, knowing what I know about this patient's stroke, where it is, what their respiratory status is, what their NIH stroke scale score is this morning. What do I expect to see from them when I go see them?
Yeah.
And then you go see them, and then was your hypothesis confirmed or was it not confirmed? And then if it was not confirmed, then you develop another hypothesis, is maybe I should dig further into this patient's medical history. Oh, he has a history of obstructive sleep apnea. Then that pulls in other things that can then better inform your decision making.
Yeah, I mean, there are always going to be limitations because no two people are exactly the same, right? Your patient is not going to be exactly like anybody who has been studied in a research study to every degree. If you go deep enough, even identical twins, I mean, there are going to be differences in nourishment and nutrition and how that affected the development of their bodies and whatnot. So the critical thinking piece, no matter how much research we have, is never going to go away. And so
absolutely.
I mean, the focus on that, I think that's why so much of what you're talking about is important, because it reinforces the critical thinking part of this. And no matter what, that is not going to go away. If we had all the research in the world, the subjects are not going to be exactly like your patient. So we've got to learn how to critically think through that to form these hypotheses based upon what we know, and then measure what we see and revise and course correct and adapt and reflect.
Right. And I think it's based practice framework, that internal evidence piece is very important. That internal evidence piece is data from your patient, data from the person sitting right in front of you. So weight that just as highly as that external, that published evidence, because we don't have all of the answers in our publications. And so what have you done with your patient, and has that worked? And then going from there, updating that, and then, documenting that and having that there. And then that can lead into a clinical trial or a case series. And so, like, let's say you tried something with this hypothetical patient and it worked, and you had a positive outcome, or it had this negative outcome, but was kind of, you thought it would work based on what we know from the research, but it didn't. That's also very interesting. If you write that up and publish it as a case series or a case study, that's that foundation of the pyramid. That gives me, as a researcher who only sees patients once a week, or a researcher who doesn't see any patients, that gives me the evidence, we call this preliminary data, in order to support me getting money from a foundation or from the NIH to actually prospectively study this in a clinical trial.
This is so good, because I think sometimes there's this perceived distance between clinicians and researchers. But the clinical work is the foundation of the research. And so
Absolutely.
by clinicians doing this, by them documenting their stuff, by them talking about it, by them collaborating with researchers, they are facilitating, enabling, dare I say, driving the research of what's going to happen. And so this echoes also some of the stuff that Alicia was talking about with her partnership with her clinicians in the ICU and different things like that. That is a huge gap that we need to bridge. And I think a lot of that is clinicians becoming more cognizant of why their data matters, of why what they're doing matters. Because, I mean, how many practicing speech pathologists are there in hospitals? I don't know. I mean, I know ASH has over 200,000 people, so pare it down, but it's thousands, maybe tens of thousands. And so there is a lot of data out there, and a lot of that data is just kind of disappearing into the EMR and after so many years being deleted or whatever.
And somewhere in packs.
It's
Studies
somewhere.
exist.
It's
Yeah.
somewhere out there. But if you realize the value in what you're doing as a clinician and are willing to reach out to researchers and collaborate, you can make such a difference. Like you can really.
Absolutely. Yeah. And then, I mean, I've just been sitting in my research office. And so I'm at UT Austin at the medical school. It's a new medical school. So we have graduated, I believe, 3 classes of med students.
Okay.
So very new medical school. And so I don't have a huge team of speech pathologists, clinical speech pathologists who I can lean on for research. And so I have a lot of these research questions. And so if you listening out there have a data set that you have questions that could potentially be answered, find a researcher, reach out to me. Like researchers need data and clinicians need research and researchers to help with those questions. And so really there shouldn't be this gap. And I talked about that imposter syndrome before, but
Sure.
there are so many clinicians out there who are much better clinicians than I am. It's on clinicians to understand that the power in their experience.
Yeah.
It's on researchers to understand the potential limitations of not being able to practice those clinical skills on a daily basis. To realize I am not the best dysphagia clinician out there because I am certainly far from the best. I have a lot of kind of background knowledge, but I don't have the time to see patients and to apply that as much as I'd like to. If I could live a double life and be a full-time clinician and a full-time researcher, maybe. But so then I need to focus my kind of technical and my research skills and then partner with those clinicians who have that clinical expertise. And then that'll help bolster the research even more.
Absolutely. We need everybody. This really exemplifies the collaborative piece, the need for synergy. You know, a part of we identify gaps. We try to figure out the causes of those gaps. We try to figure out ways to bridge those gaps. But we also, every one of us has to figure, where is my place? What can I contribute to this too? And man, I just think that is such a great way that clinicians can do that. And if that's the only thing that people walk away from this episode with is knowing how important their clinical work is to research, there we go. Like that.
And then also, you don't have to be a PhD to do research as a clinician. There are some of the best researchers I know don't have PhDs. They just have clinical degrees. And so understanding that power of the clinical experience and the creativity and the kind of curiosity of asking these interesting clinically applicable questions, and then partnering with a researcher who then will have the experience to know what kind of approvals you need and how to set up data collection and how to do the statistics and how to kind of, that kind of technical piece can help that. But again, if we want these important clinical questions to be answered and they're not being answered, the clinicians actually have some power to help get things moving.
Sure. Well, thank you so much. I really appreciate all of your insights. I think there is so much more territory to cover. Each one of these conversations opens up more territory. Thank you so much. If people would like to follow up, how can they reach you?
Yeah, my email is freely available on the internet, so I'm not worried about giving it out. It's my name, corinne.jones@austin.utexas.edu. And Tim, you're free to share that as well if people want to follow up.
Cool. And so people don't make the same mistake I did. It's one R and two N's in
One
Corinne.
or two N's, yes. Your email will get bounced back if you don't spell it right. Or we'll go somewhere into the ether.
There we go. All right, cool. Yeah, I can post that too. Looking forward to what doors of possibility this opens up. And it's always a pleasure chatting, Corinne.
Yes, thank you for the opportunity.
Thanks again for hanging out. On the subject of research, Swallow the Gap is hoping to do a podcast series interviewing authors to get their insights on how to translate their research to practice. Not everyone can easily access every article that they would like, so I'm hoping that this helps to bridge the gap between clinicians and their ability to access research. I would love your input on some articles that have been most impactful to you, so please email the titles and authors of your favorites to tim@swallowthegap.com or message on Instagram @swallowpatho, that's swallow PATHO. Keep your eyes on the Swallow Patho Instagram account. There's likely to be one or more chances soon to win a tuition refund for the upcoming webinar, Dysphagia in Patients with Pulmonary Compromise. Check it out and hope to see you there on April 20th.